Hi friends, this is Fred, and I will be taking you through the second part of Pediatric Seizures. This lecture does follow Vivian's lecture, so if you haven't watched that, go back and watch that first. So real quickly, our learning objectives. Vivian's lecture covered the first two here, so pathophys of seizures and the most common type of seizures in kids. I'm going to be talking more about how seizure presentation is a little bit different in kids and about some of the treatment options we have and why it's important to monitor people on anti-epileptic drugs for toxicity once they're started. So seizure presentation is going to be a little bit different in kids, especially under 6 years old, just because they're a little bit more difficult to assess changes in consciousness. Their seizure behavior tends to be less complex and more fragmented, and we generally don't see generalized tonic-clonic seizures in children under the ages of 2. Conversely, children over the age of 6 present more similar to adults, and so these are a little bit easier to identify when they have behavioral changes or changes in consciousness. I have a little note here. Overall, seizures, disorders, and syndromes may be characterized by type, age, and family history. So those are some important factors to consider when we're trying to find or determine the exact type of seizure. And things to keep in mind, children who have seizures or epilepsy may show delayed developmental milestones. So it's particularly important to know those milestones, especially in kids under 1 year old, because that's when pediatric seizures are most likely to take place. Kids may also show a regression in those developmental milestones and the repetition of odd or new behaviors. That's most likely the seizure activity taking place itself. All right, so that was a quick overview of how kids present a little bit differently. If you have any more questions, be sure to ask Dr. Coleman on October 13th when he's with us in class. So now I'm going to talk about anti-epileptic drugs. This is a nice figure from Nelson's Essentials of Pediatrics. So it kind of shows what we use to treat focal seizures, generalized seizures, and the nice overlap that kind of what we consider our broad spectrum anti-epileptic drugs. I kind of want to go through here. I guess first, I just want to point out that ethosuximide is a totally different type of anti-epileptic, so it's not in this Venn diagram here. But we should all know that it is the first-line treatment for absence seizures. And I kind of wanted to go through and just talk about the trade names of all these drugs too. So ethosuximide is also known as Zorantin. Carbamazepine, you'll probably hear called Tegretol. Phenytoin is also called Dilantin. Lamotrigine is pretty simple, it's Lamictal. This one with a funny name, levetiracetam. We make that a lot more simple and call it Keppra. Topiramate, also pretty simple, we call that Topamax. Valproic acid is Depakote. Clobazam, we call Onfi, and Felbamate, we call Fevitol. So just to help you a little bit when you're on the wards and they're talking about drugs, I know we always use the trade names in the clinic, so hopefully that's helpful. There's another note here under special circumstances on how we treat infantile spasms, so keep this in mind when we go through the cases. They tend to use ACTH as first-line treatment for that. You can also use corticosteroids and vigabatrin. And I want to bring your attention in the middle of this Venn diagram, right at the bottom, we have the ketogenic diet as an option for treating seizures. So I want to talk about that a bit. So the ketogenic diet is an alternative to medications or surgery, especially if the medications fail. And what this looks like is a high-fat diet. You want adequate proteins, very low carbs. So you're kind of putting the body in a starvation mode. Typically that diet, you want a 4-to-1 ratio of lipid and non-protein foods. Sorry, lipid and non-lipid foods. And they don't really know why the ketogenic diet works to prevent seizures. They think it's multifactorial in how it's actually working, but one thought is that the ketone bodies themselves are anti-epileptic. Um, and some other mechanisms have been proposed, such as increasing levels of GABA, which Vivian mentioned is the major inhibitory drug of the nervous system, or neurotransmitter of the nervous system. Just like with the medications that we'll talk about, anybody on a ketogenic diet requires close monitoring. And just some facts here. Kids who are on this diet show a 50% reduction of baseline seizure activity after 6 months, and this was seen in 60% of the study population. Even more impressive that 30% of the study population showed a 90% seizure reduction. So it can be pretty effective, but obviously it doesn't work for everyone. It's going to be indicated in those with specific inborn errors of metabolism, especially those with fat metabolism errors, like the carnitine deficiencies, also porphyrias, fatty acid oxidation defects, and pyruvate carboxylase deficiency. It's also kind of cool to know that 80% of these kids who are on the ketogenic diet remain seizure-free after 2 years, and most of them remain seizure-free after stopping the diet. So it's pretty effective, but again, requires close monitoring. All right, so when do we want to start a kid on anti-epileptic drugs? Typically, we want to start after 2 asymptomatic unprovoked seizures. The goal of this therapy is to just have them on one drug at a time, so monotherapy, and we can achieve this in about 70% of patients. Let's see. We want to, essentially, when we're trying monotherapy, we want to increase that dose until the seizures are controlled or until the adverse effects become intolerable. At that point, we may consider dropping that first agent and then adding a second agent, and kind of doing a balancing act, taking them off that first agent until we can titrate up that second agent. So the major thing here that we need to discuss are the adverse effects. Like any other drugs, there are some common side effects. So GI upset is probably one of the most common, followed by dizziness, drowsiness, mental slowing, and weight gain. But there are some pretty severe reactions that we need to be aware of. And these include gingival hyperplasia, which is mostly associated with dilantin. Also hyponatremia and agranulocytosis, which is associated with tegretol. Hepatotoxicity and thrombocytopenia has been associated with Depakote, and then the infamous Stevens-Johnson syndrome, which is mostly associated with Lamictal. I want you guys to kind of reference a table 15.3 in the blueprints for neurology. It's just a nice breakdown of a lot of these drugs, their site of action, the seizure types that they are used to treat, and the side effects. So that was my primary resource here. All right, when it comes to monitoring kids on these drugs, anytime they come in with suspected seizure activity, we want to get a baseline lab draw. That's going to include a CBC and a CMP, mostly looking for any electrolyte imbalances or metabolic reasons that they could have a seizure. And also get a baseline of liver function and kidney function. So once we do start them on the drugs, we can monitor that going forward. One thing that I found when I was reading up on monitoring is that Asians in particular are more predisposed to Stevens-Johnson syndrome, especially if they have this HLA-B1502 phenotype. So it may be important to screen Asians coming in with seizures for this phenotype, because we want to avoid giving them carbamazepine and phenytoin. And we also need to consider additional things in girls or adolescent girls, especially after they started menstruating, or if they're on birth control, because they can influence either the levels of the AED or the AED can influence the levels of the hormonal birth control. So in that case, we'd prefer them to be not on non-hormonal forms of birth control. And reasons that it affects this is that, some of these anti-epileptic drugs are inducers of hepatic enzymes, particularly carbamazepine, phenytoin, and phenobarbital. Um, so we have patients on those drugs definitely avoid hormonal contraceptives. Uh, it's also important to note that some of these drugs are known teratogens. So if a woman is suspecting to get pregnant, we definitely want to maybe try to get her on a different drug with less teratogenicity. And I have some listed here. So valproic acid um, has been known to cause neural tube defects. So phenytoin and phenobarbital have been associated with orofacial cleft defects, cardiac and genitourinary malformations. And then carbamazepine has been associated with spina bifida. So those are just things to consider. Obviously, if a woman does get pregnant and she's on some of these medications, um, we want to consider switching her to something that's a little less teratogenic, um, but also kind of weigh the risk and benefits because having a seizure while pregnant is probably more harmful than um, the risk of teratogenicity. So just something to consider. All right, so a little bit more on monitoring. Um, we typically want to get blood levels once the seizures have been controlled. This is to compare blood levels in the event of a breakthrough seizure, and that's typically caused by noncompliance. The parents or the patients just stop taking the medication, so we want to know exactly what is the level that they're at and if they are taking it. And it's important to note that therapeutic levels are different for everyone, so we're not really going for a specific blood level for our target, but really our therapy is guided by seizure control and tolerance to adverse effects, as stated before. And in terms of follow-up labs, we typically want to follow up on those same labs, so CBC and CMP, within the first 3 to 6 months of treatment, as this is when side effects are most likely to occur. And in a resource I had read said that frequent monitoring may not be necessary in kids who are stabilized after this 6-month period, but you always want to maintain a high index of suspicion for adverse events for anyone taking these drugs because some of the effects are so or can be deadly. And just a quick note, so that's it for medications for treatment of epilepsy. Now we have some other treatment options. One thing that's interesting is vagus nerve stimulation. It's typically reserved for patients with seizures refractory to medical management or who do not want to undergo surgery or are not good candidates. And what this looks like is they typically attach electrodes to the left vagus nerve, usually in the neck, and they don't know exactly why this works, but they're studying many mechanisms to see why. And from what I've seen in clinic, the vagus nerve stimulator itself kind of looks like a pacemaker that sits just subcutaneously on the chest, and it sends regular shocks to the vagus nerve at a certain frequency. How it works again, I'm not too sure. Of course, another option is surgery, also reserved for patients refractory to medical management. I have different types of surgeries listed here. So we do resection of the epileptogenic region, particularly in seizures with a more focal cause. We can also do corpus colostomy, hemispherectomy, and multiple subfield transection. And hopefully Dr. Coleman will talk a little bit more about those. And lastly, because I'm covering treatment, I want to talk about status epilepticus. So we all know that this is defined as seizures prolonged and lasting more than 5 minutes, are multiple seizures within a 5-minute time frame that don't have a return to normal activity. Anytime this happens, there's a particular sequence of events that we need to do to make sure that the patient's safe and getting proper treatment. The first of those is going to be to monitor and assess the ABCs. If we can, we also want to perform a glucose finger stick just to make sure that that's not a cause of the seizure. Then we want to establish IV access because that's how most of the drugs we're going to administer are going to be placed. And administer thiamine and dextrose before we do any of these anti-epileptics. So the first line on anti-epileptics is going to be lorazepam. If the seizure does not resolve with that, we move on to phenytoin. Again, if the seizure does not resolve, we go to our next step, which is phenobarbital. And if for any reason these three agents have not resolved the seizure, we're going to do something a little more drastic and induce a coma with barbiturates, midazolam, or propofol. So that was kind of a whirlwind. I hope that gives you a better idea of how kids present differently with seizures and some of our treatment options and why it's important to monitor children once we have them on medications. So here are our resources. Again, Blueprints for Neurology is going to be our best resource in preparing for our shelf. Great. If you have any questions, Vivian and I will be happy to address them this Friday, October the 13th. Friday the 13th. We'll see you then.